Hello and welcome. Today we're going to be talking about one of the most significant evolutions in critical care over the last couple of decades. How we decode a patient's cardiac output and hemodynamics without using a Swan-Ganz catheter. This is a practical guide to understanding the modern tools we use at the bedside to get dynamic, real-time information about our sickest patients. For many years, the pulmonary artery catheter, or Swan-Ganz, was the undisputed gold standard. It gave us our core numbers: cardiac output, CVP, PA pressures, and SVO2. But as we all know, it's a highly invasive procedure with significant risks, including arrhythmias, infection, and even pulmonary artery rupture. Furthermore, it gives us static data, a snapshot in time. And perhaps most importantly, multiple large-scale studies began to question whether its use actually improved patient outcomes. This led to a major shift in thinking. The goal today is to get better, more dynamic, and more actionable data with far less risk to our patients. Now, even though the technology has changed, the fundamental physiology has not. Our goals are still rooted in these two simple equations. First, cardiac output equals heart rate times stroke volume. This tells us that if we can figure out the stroke volume, the amount of blood pumped with each beat, we can easily determine the cardiac output. Second, the equation for systemic vascular resistance, or SVR. It looks complicated, but it's just the relationship between pressure, flow, and resistance. If we have the map, a CVP, and now the cardiac output, we can calculate the SVR. The entire challenge of modern monitoring, therefore, boils down to one thing: finding a new and better way to measure stroke volume. The most common way we do this today is with pulse contour analysis. This technology uses a standard arterial line that you're already placing in your patient. The principle is that the shape, or contour, of the arterial pressure wave is directly related to the stroke volume. A bigger, wider waveform means a larger stroke volume. A specialized monitor, like a FloTrac system, analyzes the shape of this pressure wave, pulse by pulse in real time. From that shape, its algorithm calculates a beat-to-beat stroke volume, and from there, a continuous cardiac output and SVR. Think of it as the monitor reading the unique story of each heartbeat from the pressure wave it creates. The second major method is using point-of-care ultrasound, which gives us a direct, visual way to measure stroke volume. The concept here is pure physics. If we know the size of the pipe the blood is leaving through, and we know how far the blood travels with each beat, we can calculate the volume. So we use the ultrasound to measure the diameter of the left ventricular outflow tract. That's the pipe. Then, using Doppler, we measure something called the velocity time integral, or VTI, which is the distance the blood travels with each beat. The machine then calculates the volume of that cylinder of blood, giving us a very accurate, non-invasive stroke volume. This is often considered the non-invasive gold standard. There are also completely non-invasive methods like bioreactance. These systems use sensor pads placed on the patient's chest. They pass a tiny, imperceptible electrical current across the thorax. As the heart beats and ejects blood into the aorta, that big pulse of blood changes the electrical properties of the chest just slightly. The monitor detects this change, and its algorithm correlates the size of that change to the stroke volume. The major benefit here is that it requires no invasive lines at all. So now we have all this data. What do we do with it? We build a hemodynamic profile to understand the type of shock our patient is in. In cardiogenic shock, the pump is broken. The stroke volume and cardiac output will be low, and the body compensates by clamping down, so the SVR will be high. In hypovolemic shock, the tank is empty. The profile looks identical: low stroke volume, low cardiac output, and a compensatory high SVR. But in distributive shock, like sepsis, the story is completely different. The pipes are wide open, so the SVR is very low. The heart tries to compensate by beating faster and harder, leading to a high cardiac output, at least in the early stages. This is where continuous monitoring becomes so powerful. Static numbers like CVP are terrible at predicting who will respond to fluids, but dynamic numbers like stroke volume are excellent. We use the Frank-Starling law. To see where our patient is on this curve, we perform a fluid challenge, like a passive leg raise. We then watch the stroke volume on the monitor. If the SV increases by 10 to 15%, we know the patient is fluid responsive, and more fluid will likely help. If the SV doesn't change, the patient is on the flat part of the curve. Giving them more fluid will not increase their cardiac output and will only lead to volume overload. This is physiology-based resuscitation in real time. Let's look at a case. A 68-year-old post-MI. He's hypotensive with a MAP of 62. His non-invasive data shows a very low stroke volume and a low cardiac output. In response, his SVR is very high at 1600. What's the story? The pump is failing and the body is clamping down to compensate. This is a classic picture of cardiogenic shock. The treatment here would be inotropes, not fluids. Let's look at another case. A 45-year-old with pancreatitis. She's hypotensive with a MAP of 53, but look at her data. Her stroke volume is robust, and her cardiac output is high at 8.5. Her SVR, however, is incredibly low at 450. What's the story here? The pipes are wide open, and the heart is working overtime to compensate. This is classic early distributive shock. The treatment is vasopressors to tighten the pipes and fluids. Of course, no technology is perfect. Pulse contour analysis can be less accurate with arrhythmias like AFib or with significant aortic valve disease. Echocardiography requires a skilled user and can be difficult in some patients, and all of them depend on good quality inputs. A dampened arterial line will give you garbage data. The most important rule is to always treat the patient, not the monitor. Correlate the data you're seeing with your clinical exam. So, to summarize, we have moved from invasive, static measurements to less invasive, dynamic data. By measuring stroke volume, we can calculate CO and SVR to build a hemodynamic profile and diagnose the type of shock. And most powerfully, we can use dynamic changes in stroke volume to assess fluid responsiveness and guide our resuscitation at the bedside. The future of hemodynamics is here. It's less invasive, more dynamic, and allows us to make real-time, physiology-based decisions that are tailored to the individual patient. Thank you for your time, and I'm happy to take any questions.